Start, ma'am. We are learning.
So, good evening, everyone, and good evening, all the faculty and delegates to join today's session. So, it's a great pleasure to welcome you all today webinar, Current Oncology Update, Series 10. And I would like to invite Dr. Rajat Bajaj, sir. He's a Director Medical Oncology, IOCI Fortis Hospital, Noida, to give his opening remarks. So, it's over to you, sir.
Yeah. Uh, Good evening, everyone. Thank you all for joining in today, day two of this webinar that we are doing for the updates in oncology. Today, the session one is going to be on breast cancer. And without any further delay, the first topic is escalation and de-escalation in the neoadjuvant or the adjuvant systemic therapy. What is proven? And to discuss this topic, we have with us Dr. Sahu sir from Bhopal. He needs, of course, no introduction. Sir, good evening.
Good evening.
Sir, all yours.
Yeah. So I'll share the slides. Just someone tell me. Yes.
Yes, sir,
Hello.
it's visible.
Yeah. Yeah. So I will just if my internet connection gets cut, just let me know. So in the next 10 minutes, so I'm starting at 7:05. So by 7:15 I'll finish, and it's my topic given to me is escalation and de-escalation in not if it in the systemic therapy for new adjuvant setting and adjuvant setting for early breast cancer. So I'll be touching very briefly on the HER2 new hormone is a positive and TMBC, and we'll be going through what is proven and what is normally we do as a practice. So HER2 positive early breast cancer, all of us know that 15% of these are HER2 positive, and the guidelines have shown that trastuzumab decrease the risk of recurrence by one third when added to chemo. And if you look into that, if a chemotherapy and trastuzumab both are taken together, then you have a decrease in around 50% in the risk of the breast cancer coming back. And this is a meta-analysis which was put up 2 3 years back of around 14,000 patients to tell us the benefit of trastuzumab, and it is believed that the hazards is 0.66, that we have a 30 to 4% chances of a lesser relapse if you add trastuzumab to this setting. And this was irrespective of the age, the hormone receptor status, and the nodal positivity, and even the tumor diameter. Although there is some thought process that probably the very small, less than 5 millimeters or maybe 1 centimeter, do not benefit that much, and most likely the hormone positive ones. But the data is not that robust, and we do not have any randomized trial. And whatever has come out is through a lot of meta-analysis and data which has been taken together from the subgroup analysis of multiple trials. This is the one trial which is there and which is proven that yes, if you have a small tumor, specifically below 2 centimeters, although it did take, the APT trial did take till 3 centimeters, but that was a minority, 9% of patients. And this trial at a 10-year analysis shows something, that the invasive disease-free survival is around 91 to 92%, with the OS of around 95%. So basically, if you de-escalate and just give a weekly paclitaxel and a trastuzumab for 1 year for the patients who are technically node negative, T up till 3 centimeters, but predominantly till 2 centimeters, irrespective of the hormone status, they would benefit, and the overall survival was at 10 years was around 95%. So coming down to, they tried to look into something known as HER2-DX, as we have Oncotype DX hormone positive, and they found out that if the cutoff of the HER2-DX was 32, the patients who had more than 32 as a cutoff, the upper score being 100, did very poorly than those who had a score of less than 32. But do we need to escalate the patients to for a better benefit for those who have a high score? We don't know as yet. There is a small data set for TDM1 which was compared to again the APT protocol. Just to tell you, this was not a trial designed to compare the TDM1 to the APT protocol. Just look at the toxicity, that whether TDM1 is lesser toxic. To cut things short, it looks a very good regimen. Although it was a phase 2, the TDM1 looked exceptionally good as the APD regimen. But the most important was it was equivalent in toxicity. It was expected to have a 40% decrease in toxicity, which it did not. So TDM1 is not a standard of care, but there is data set that someone who cannot receive a trastuzumab or taxane, TDM1 could be option, but not a level 1 evidence. For duration of trastuzumab, quickly we know from Tata Memorial there was a meta-analysis of individual patient data which was taken by Dr. Sudeep and his team, and they have told that a shorter course trastuzumab of 9 weeks was probably non-inferior to the 6 months to 1 year. But the thing I want to make out is the margin of non-inferiority is something that we need to take care. And if the margin non-inferiority is little sharper, let's say 1.24 or 1.15, which is lesser than 1.3 or 1.29, which has been taken in Persephone or the Dr. Sudeep's meta-analysis, you do find that the shorter duration of trastuzumab actually is inferior and not proven to be non-inferior. So to cut things short, what I would recommend and what the data set tells you that probably a year of trastuzumab is the best way to go forward, and you should be very cautious to cut short the duration of trastuzumab, especially for patients whom you do not give anthracyclines. But if you want to and need to, probably patients who have less than 1 centimeter, ER positive patients, you could go away with 6 months. For 9 weeks, I'm not pretty sure whether I will go ahead with anyone with 9 weeks. For dose escalation, this is the Catherine data for those who have received a neoadjuvant single or dual HER2 target therapy plus chemo. If they do not achieve a PATCR, they were randomized to continue trastuzumab versus TDM1, and it proved that change of therapy did matter. So you should escalate for patients who do not achieve a PATCR, and this was seen across subgroups of patients. For patients who actually go ahead and get operated upfront, there is affinity data set which compared trastuzumab, pertuzumab chemotherapy to chemotherapy or trastuzumab, which is a standard of care. It was a placebo-controlled trial, a double-blind trial, and it showed one thing, that if you have a node-positive patient, you should be offering adjuvant trastuzumab and pertuzumab to these patients. Otherwise, for node-negative, addition of pertuzumab really does not help. So this is something which I think makes care of the HER2 positive patients who we need to de-escalate and escalate. So my take, if you have a tumor 1C, this patient of HER2 positive will require chemotherapy with trastuzumab, and the trastuzumab should be ideally 1 year. 1B, again, we require chemo with trastuzumab, preferably 1 year. 1A, less than 5 millimeters, we need to discuss. You may refrain from any form of trastuzumab, but in ER negative, probably most of us would go for a shorter duration, probably of trastuzumab with chemo. For TMIC and node negative, the data set is you should not be giving trastuzumab. Duration of trastuzumab with Paclitaxel alone should be 1 year. Hormone positive, preferably 1 year, could be 6 months if there is a financial concern. So this is what the data set. And if anyone is node positive, has been operated, you should go for a pertuzumab, trastuzumab. And anyone who has received a neoadjuvant HER2 target therapy plus chemo does not achieve a PATCR, TDM1 is the way to go ahead, and that is what has been shown superior to continuation of trastuzumab. Switching gears to triple negative breast cancer, and this is something that we need to know, that anything beyond T2 or N0, N plus, should be receiving a new adjuvant form in the triple negative. Even if they are BRCA mutated, there is no data set for a new adjuvant PARP inhibitors. So there are multiple trials, but the most spoken about trial is the Keynote 522, and their overall survival prolonged, and the last analysis was published 2 months back in NEJM. This did show that the addition of immune checkpoint to the chemotherapy skeleton in the neoadjuvant setting with the taxanes and anthracyclines showed superiority to no immunotherapy addition to the chemotherapy skeleton. But if you look at the graphs, and especially the initial part of the graphs in the first 2 to 3 years, the graphs are crisscrossing each other. So basically, the hazard was non-proportional. To be very clear, it was a 0.66, 32%, 34% benefit of addition of pembrolizumab, but that thing is not that simple because the hazards was non-proportional. And then we look at the RMST, and the RMST data looks not so impressive to me. And at a difference of 3 years, the addition of immunotherapy adds only 0.2 months to survival, 4 years, 0.6 months, and at the end of 5 years, additional immunotherapy for 1 year only adds around a month of survival. So if you have a PATCR, can you take away the pembrolizumab? Can you do that? Most of us believe yes, but you do not have a level 1 evidence. At this point, you should be continuing the protocol for 1 year. That's what it is. But you may individualize it. But patients who do not achieve a PATH CR, definitely continuing the Pembro for 1 year did make a difference. Can we, do we need to just add carboplatin or platinum in the neoadjuvant? And if someone has been operated upfront, can we do carboplatin in the adjuvant setting? So we had some data set before, but now the Pearly was read out in this ASCO. And this was a very simple trial where 70% were neoadjuvant and 30% of the triple negative received adjuvant platinum. And the cut thing short, it showed that platinum in any form, in a triple negative, preferably neoadjuvant. But if I'm not given in neoadjuvant, in adjuvant setting also matters. So for me, I have definitely changed my practice at this point of time. And they did not matter with the pre or post menopausal, as was done with the Tata Memorial Hospital paper by Dr. Sudeep and group, that only the pre-menopausal benefited from platinum. But in the DAISY from Korea, it showed that actually, irrespective of the menopausal status, they did benefit. Do we add immunotherapy in the adjuvant setting if you have not added the new adjuvant? No. At this point, avelumab data set shows you that the primary endpoint was not met. So what do I do for post patients who have not achieved a PATCR, for someone who have given new adjuvant treatment without immunotherapy? The data is very clear that the Createx told that we should add capecitabine, but addition of capecitabine versus platinum, there was a comparison trial and it showed both are equivalent, only platinum had more toxicity. Can we add platinum to immunotherapy in 522 protocol? No level 1 evidence, but people feel that yes, you may add immunotherapy with capecitabine for patients who do not achieve a PATCR. So this is what it will be a schema of things for me for triple negative breast cancer. Last part of my talk is again going to be in 2 slides for the hormone positive in a minute. So patients who are at least having till 3 nodes positive, who are ERPR positive, HER2 negative. At this point, we want to do a Oncotype DX or a MammaPrint like scoring. And what it happens that if the patient is postmenopausal, till the risk score of 25, you may not benefit from adding any chemotherapy. But if the patient is premenopausal, the risk score, the recurrence score actually comes down to around 14, 15. And beyond that, there is a benefit, not like the cutoff of 25. But if the patient is lymph node positive in the premenopausal, irrespective of what it is, even if one node is positive, you should be adding chemotherapy. If the lymph node is negative, then probably around 15 is the cutoff, and for the postmenopausal is 25. So my take home for the adjuvant therapy for escalation, de-escalation is postmenopausal recurrence score below 25 in Oncotype DX, up to 3 nodes, no chemo. Patients, especially node negative, risk score, recurrence score of less than 11 or low risk as per the MIND Act, can be offered hormone therapy alone, but one should also take into account the grade of the tumor and the size of the tumor. Ultra low risk is something that is not a level 1 evidence, but that is coming up, that even we can de-escalate the hormone therapy also. The duration may be de-escalated instead of 5 years to around 2 years. That's something that is developing, not a standard of care. Women with less than 35 to 40 years, those are premenopausal, especially should benefit from ovarian suppression, especially those women who have received chemotherapy, who require chemotherapy and are node positive. In younger patients with higher composite score of recurrence, overall ovarian suppression with AI appears better. And one could choose AIs over tamoxifen based on the higher risk and the Ki67. For escalation in the hormone positive, we know the monarchy and the Natalie data set. So patients who are having the inclusion criteria as prescribed in both the trials should be offered. The only thing I want to tell you is the monarchy is for the very high risk beyond four or more lymph nodes, or 1 to 3 there are risk criteria, size 5 centimeter, grade, and this is what it is. Ki67 is not a criteria anymore. There's benefit in terms of IDFS scores for 2 years of abima, but we are getting up data sets for Natalie as per the inclusion criteria, that 3 years of 400 milligrams of ribociclib has shown benefit of IDFS, but marginally the numbers are inferior to that we see in the monarchy. So with that, I will stop, and I think I have exceeded the time by a minute, but this is what it is for the escalation and the de-escalation of the neoadjuvant and adjuvant therapies in early breast cancer. Thank you.
Thank you very much, sir, for this very crisp presentation encompassing everything, I suppose. I think everything in the subtypes of breast cancer, be it escalation or de-escalation, have been discussed. So your viewpoints on the neoadjuvant immunotherapy used in HR positive, HER2 negative. There were two trials in the high grade subset of ERPR positive, HER2 negative. So have you adopted that in your practice, or do you want to wait for more data to come in?
For the hormone, you are talking of the hormone positive data set, na? So the
Yes,
hormone
yes, sir.
positive data set. I'm clear on that only. You are asking me.
Yes,
No, I have
yes, sir.
not
Hormone
adopted.
positive.
And even for the keynote 522, after going through the final paper, which is in the New England Journal published 2 months back, with the RMST curves and the data set which I showed you, I am still feel that this is a protocol that is probably not that beneficial as the non-proportional hazards of 0.66 is showing us. So even Rajat, I'll be very clear that I am also, I will offer it to my patient, but I probably will not push it. Platinum is something which I'll be pushing and pushing. Immunotherapy for the super rich maybe, but after looking at the survival curves, the crossing over of the survival for the first 2 years, and mind you, the hazards were non-proportional in the first 2 to 3 years. The hazards was only 0.89, if I'm not wrong. So basically, the benefit was seen in the later part
Yes,
is non-proportional. I am still very little bit taken back after the full paper, even for the benefit of Pembro in the new adjuvant and peri adjuvant setting for the 5 lakh that keynote 522. So we should look beyond curves and look at the paper, and you will find there are questions which are open. And I think we need better combinations even in triple negative. So for immunotherapy, for me is very selective. I'm not pushing it really for all my patients. But for triple negative, chemo must. I will definitely push for it. HER2 new, I will push for new adjuvant. That's no doubt about it.
right, sir. Right, right.
Okay.
Thank you so much once again for this
Thank you.
nice presentation. Thank you. Gitika, please take it forward.
Okay, sir. So for the next session, this session is sponsored by Roche, and I would like to invite Dr. Vishnu Hari, sir. He's a senior consultant, Department of Medical Oncology, Bone Marrow Transplantation and Cellular Therapy, Sarvodaya Hospital, Faridabad, and to give us talk about a flexible future transforming the paradigm of HER2 positive breast cancer treatment. So it's over to you, sir.
Hi, hello,
Yes, sir, your voice
hello.
is audible.
Okay, so I'll share my screen.
Yes, sir.
Hello, hello. Am I audible? Hello, hello, hello.
Yes, sir, you are audible.
Okay, there is some issue with the connection. I think I'm not. I'm not getting any feedback. Shall I start?
Yeah, you can start.
Okay. So first of all, I would like to thank the organizers, Dr. Rajat and Roche, for giving me this opportunity to talk on this subject. So I'll be talking today. I'll be talking today about the impact of dual HER2 blockade on patients with HER2 positive breast cancer. Um, so, as we all know, breast cancer is the most frequent and leading cause of cancer death among females. The lifetime probability of developing CA breast is approximately 1 in 8. So among all the breast cancers, HER2 positivity accounts for around 15% of the cases. So we are familiar with the algorithm for this for the HER2 testing by IHC. If it is 3 plus, then it is considered as positive. And if it is 2 plus, then we have to go for fish. If the fish ratio is less than 2, then we have to look at the HER2 copy number. If it is more than or equal to 6, then it is considered as positive. And if the fish ratio is more than or equal to 2, then again we have to look at the HER2 copy number. And if it is more than or equal to 4, then we take it as positive. So these are the some of the major trials with regard to dual HER2 blockade in the HER2 positive setting. In neoadjuvant setting, we have the Neosphere trial. It was shown in this trial that addition of pertuzumab to trastuzumab with chemotherapy in the neoadjuvant setting improved the total PCR rates from 31% to 49%. And we have other trials also, Trifina, Berenice, and Peony also showed improvement in PCR rates. And in the adjuvant setting, we have the affinity trial, which showed an improvement of 19 percentage reduction in risk of IDFS, which was more prominent in the node positive subgroup. And in the metastatic setting, we have the Cleopatra trial, which showed improvement of median PFS from 12.4 months to 18.45 months versus trastuzumab alone, and the median OS was also improved from 40.8% months to 56.5 months. So the current status of dual HER2 blockade is NCCN recommends preoperative or perioperative dual HER2 blockade in locally advanced HER2 positive disease. If there is residual disease after surgery, then we have to change it to TDM1. And in the adjuvant setting, the recommendation is to use adjuvant chemotherapy plus dual anti-HER2 blockade in the node positive setting, irrespective of the hormone receptor status. And in metastatic setting, the first line treatment is dual anti-HER2 blockade with either docetaxel or paclitaxel. And ESMO also gives similar kind of recommendation. And in the neoadjuvant setting, the rationale for dual HER2 blockade is the improvement in PCR. Achievement of pathological complete response is associated with highly significant improvement in EFS and OS in patients with HER2 positive disease, as shown in some large meta-analysis. And in this meta-analysis, it was shown that achievement of PCR improved overall survival and EFS rates. And this is another pooled analysis. It was also shown in this trial that the achievement of PCR improved both EFS, DFS, and OS. So this is another pooled analysis by Swain et al. It was compared in this trial the use of single agent anti-HER2 with dual blockade in preoperative, neoadjuvant, and in perioperative setting compared to single agent trastuzumab. The addition of dual anti-HER2 blockade in the neoadjuvant setting and in the perioperative setting both improved EFS rates. And this EFS improvement was irrespective of the achievement of EFS rates in both the setting. So this slide summarizes the trials comparing single agent trastuzumab versus dual HER2 blockade in the preoperative setting. It was shown that the PCR rates are consistently improved in the rates of 15 to 25% with the addition of pertuzumab to trastuzumab. So this is another trial in the perioperative setting which showed cardiac safety with addition of dual anti-HER2 blockade. In this study, it was shown that there was the adverse events were similar in both the cohorts, and 5-year EFS rates were similar across both the cohorts. And it was also shown that patients with PCR had better EFS rates compared to patients who had residual disease. And this is another trial, a Peony trial. This was also an efficacy, safety, and tolerability trial of dual anti-HER2 blockade with docetaxel. And in this trial also, it was shown that dual anti-HER2 blockade improves EFS and DFS rate consistently. And in the OS overall survival analysis at 5 year, it was shown that there was a trend towards improved survival, but it was not statistically significant. And the side effect profile were largely comparable. The major adverse events in the dual anti-HER2 blockade was diarrhea and an increased incidence of upper respiratory infection. The cardiac side effects were comparable in both the groups. And in adjuvant setting, we have the affinity trial. In this trial, it was shown it was compared, trastuzumab dual anti-HER2 blockade was compared with the single agent trastuzumab. It was a placebo controlled trial. Baseline characteristics were well balanced. At and in the interim overall survival analysis at 8.4 years, the median for survival was not much different between the two groups. In the intensity to treat population and in the node positive cohort. However, the IDFS in the IDFS analysis, there was a slight improvement in the intensity to treat population. The difference in EFS was 2.6%, and in the node positive cohort, the difference was more significant. There was a difference of approximately 4.9%. So summarizing, there was only a 0.7% difference in the overall survival between the two arms. However, the node positive cohort derives benefit from adding pertuzumab. So the current guidelines is patients in the adjuvant setting should receive, node positive patients should receive dual HER2 blockade irrespective of the hormone receptor status. So the next question is whether to give IV therapy or subcutaneous therapy. So IV therapy adds to a lot of logistical and logistical burden to the lives of HER2 positive patients because of the physical pain, discomfort, and emotional impact of exposure to other cancer patients in the infusion ward. So the nature of the burden faced by patients on IV treatment differs depending on the stage they are at in their infusion journey, specifically time since diagnosis and whether it is an early disease or a metastatic disease. And it may also depend on their own life circumstances like dependent children, working status, and distance from the infusion center. And it also depends on the support available to them, like financial support or emotional support. So IV duration infusion is only one aspect of patient's appointment day. It includes travel, screening, blood tests, waiting time, and cannula insertion. When coupled with many other elements to the process, the day becomes long, tiring, and emotionally exhausting for patient. It could last up to 10 hours. So this could add to anxiety, frustration, guilt, and isolation, which ultimately will lead to depression. It was shown in many trials that depression is associated with cancer recurrence, all-cause mortality, and cancer-specific mortality. So there comes the significance of subcutaneous preparation, FESGO. It contains the same antibodies as approved for IV Perjeta and Herceptin, but as a different route of administration. It is formulated with recombinant human hyaluronidase to allow subcutaneous administration of higher drug volumes. And it is a ready-to-use fixed drug formulation administered by a subcutaneous injection in the thigh over approximately 5 to 8 minutes. So the efficacy of FESGO over IV preparation was shown in this trial, Federica trial, which was a phase 3 study comparing the pharmacokinetics, efficacy, and safety of FESGO versus IV preparation. So the primary endpoints were non-inferiority of cycle 7 pertuzumab serum trough concentration. Secondary endpoints were non-inferiority of pre-dose cyclate trastuzumab trough concentration, PCR rates, DFS, EFS, and OS. Baseline characteristics were well balanced, and in this trial, the study met its primary endpoint, that was the cycle 7 pertuzumab serum trough concentration. So the serum trastuzumab trough concentration was also non-inferior to IV preparation. Fesco had almost identical total PCR rates compared to IV preparation in this trial, and PCR rates were consistent across stratification factors like hormone receptor status, clinical stage at presentation, and types of chemotherapy. And yeah, BMI body weight also did not impact the efficacy of Fesgo in this trial. The cardiac safety between the two arms were also comparable. So it was shown that it was an effective and safe Fesgo is an effective and safe alternative to IV preparation. And this is another trial, Francesca, which is a phase 2 open label randomized crossover study evaluating patient preference for Fesgo versus IV preparation. And the primary objective was to assess patient preference for Fesgo. So at the primary analysis, 85% of the patients preferred FESCO over IV preparations, regardless of the sequencing. So the main reasons for sub-Q preference were it requires less time in the clinic, it feels more comfortable during administration, it feels less emotionally distressing, and it feels lower level of injection site pain. So approximately 66% of the patients felt restricted when receiving IV preparation compared to 27% of the patients receiving FESCO. So majority of the healthcare professionals also preferred FESCO over IV preparation. So they felt that it would save time and resources during preparation and treatment. So after a long-term follow-up, efficacy data remains immature, but high 3-year IDFS and OS rates were seen with FESCO compared to IV preparation. Then there is this Fatima trial. It is a phase 3 multi-center randomized open label study. Its primary objective was to find out whether it is time saving for patients and HCPs with FESGO compared to IV, both pertuzumab and trastuzumab IV versus pertuzumab IV plus trastuzumab subcutaneous preparation. So in this trial, it was shown that FESGO significantly decreases mean time per cycle spent by the patients compared to both IV and IV pertuzumab plus subcutaneous trastuzumab preparation. So the healthcare professional time cycle was also reduced with FESGO. So in summary, FESGO treatment resulted in significant time savings for patients and healthcare professionals compared with IV and pertuzumab IV plus trastuzumab subQ. Use of several medical consumables were reduced with FESGO, and um, uh, uh, taken together with the efficacy, safety, and patient preference data for FESGO, Fatima supports the use of FESGO versus IV preparation for HER2 positive breast cancer. In summary, dual HER2 blockade is the standard of care in early breast cancer setting. It is associated with improved DFS and potentially OS. There are no additional safety concerns. Subcutaneous preparation, FESGO is associated with similar outcomes compared to IV preparation, and it significantly reduces time and stress compared to IV preparation, and it can be safely substituted for IV preparation. Thank you.
Thank you so much, Dr. Vishnu. Is there
Thank
any
you.
question to Dr. Vishnu? Okay, sir, stay back. So I
Okay.
would like to invite Dr. Rajat Bajasa for the next session. And session is evolving trends in HER2 positive MBC. So it's over to you, Dr. Rajat.
Yes. Am I audible?
Yes, yes.
Okay. Can I have my slides, please? Yeah. So I'm going to talk about the evolving trends in the management of HER2 positive MBC. Next slide. We're going to talk about the HER2 positive MBC, what is the unmet need in the second line, recent advances in HER2 positive MBC with the coming up of trastuzumab deruxtecan, neratinib, which is soon to be launched in India, tucatinib, tucatinib, which is soon to be launched in India, neratinib, which is there, but a toxic therapy. How do we really make use of that therapy? The NALA trial and the current treatment algorithm for HER2 positive MBC. Next slide. So if we talk about HER2 positive MBC, there are about 20% patients of all MBCs that we see which are HER2 positive. So it can be a ERPR positive HER2 positive MBC, or it can be a ERPR negative HER2 positive MBC. ERPR negative HER2 positive MBC is more common and is more aggressive. But we all know that HER2 positive breast cancer is overall an aggressive disease, where there are chances that this disease would metastasize even if treated with a curative intent in the beginning. And of course it depends on the initial stage that the patient was in. 30% of these patients can become metastatic after diagnosis, so we have to be careful as to how we manage these patients in the best possible manner so that the disease and the curative intent remains intact. Next slide. Next slide, please. So there have been few discoveries which have shaken the foundation of cancer treatment, like the discovery of a HER2 oncogene. HER2 oncogene was discovered and was found to be a gene where the cancer cell gets addicted, and that is why there is proliferation and angiogenesis. And if we are able to curb this gene, then not only in breast cancer, where it is the most common and the most prolific way of reducing the disease proliferation in this positive subset, there are other sites also where this gene has been found to be useful as a target, be it gallbladder malignancy or urinary bladder malignancy or a GI malignancy. Next slide. So what is the unmet need in a HER2 positive MBC? Next slide. As HER2 targeted options continue to expand, the physicians they weigh many factors while sequencing the treatment. One has to understand that not all patients who would start as first line metastatic would go on to receive second line metastatic therapy. There are about 20% patients who do not receive a second line therapy, and from a second line to a third line, about one third of the patients do not receive a third line. So what that means is that there are several decision factors that have to be taken, and the best bet or the best weapons for the treatment of a particular disease should be used upfront so that the patients can maximally benefit. Next slide, please. So if we talk about the key data supporting the existing therapies in MBC, we have the Cleopatra regimen, which is still the first line therapy, and we know that it constitutes docetaxel, pertuzumab plus trastuzumab. And here the response rates were seen as about 80% with CR of 6%, and the PFS in this patient was nearly 20 months, which was in a delta of 6 months from the comparator arm of trastuzumab alone, with a median overall survival of about 60 months, which was an improvement of 15 to 16 months over and above the comparator arm. So it was a highly positive study, and it also reaffirmed the fact that patients who are getting a pertuzumab based therapy are not going to have a worse LV ejection fraction or a heart side effect or a cardiac side effect as compared to patients who are getting only a single agent HER2 blockade. That also was quite a big relief. And this therapy is fairly well tolerated if we are able to take care of the diarrhea and the neutropenia part. Next slide. Now, second line therapies, there have been many. So, second line therapies, we have the trial which told us about TDM1 versus Lepatinib plus capecitabine, which was the standard of care till the time Emilia came in 2015 in NEJM. And there was an improvement in PFS and OS both. And that is why it was a positive study. A PFS of 10 months was a good enough PFS in about 1,000 odd patients it was seen. And that is how it actually came on to become the second line therapy, TDM1. And Lapatinib plus capecitabine went on to become the third line therapy. Next slide. But we all know that PFS drops by approximately half when the patient is moving from a first line therapy to a second line therapy. One can see that Cleopatra and Amelia trials, these are cross trial comparisons, but one can see that the PFS it decreases. And one can also see that the Cleopatra and the Amelia studies were conducted simultaneously. So one has to understand that the real world studies on the second line TDM1 are also a lot of them are there, especially following pertuzumab as well. Whereas in Amelia, per TDM1 was used in second line, but there were hardly any patients where pertuzumab was given. So it is a sequence which can easily be done. But yes, from moving from first line to second line, the efficacy of the drug reduces, and there is no doubt. Next slide. Now, evidence suggests that the PFS outcomes for second line TDM1 are worse in patients who receive prior pertuzumab. So, these are real world data, and if we talk about patients who have used pertuzumab in the beginning, then we have a lesser PFS compared to patients where there is a pertuzumab naive sort of a scenario. And these are supported by two large real world Italian studies which have evaluated second line TDM1 after a pertuzumab exposure versus a naive population. Next slide. So what it actually means is that if we are talking about the exposure of pertuzumab in almost all patients in the beginning, which we want to do so that we can extend the benefit of Cleopatra and its robust PFS, and if you're using TDM1 in the second line, are we only adding about 4 to 5 months to the PFS is what probably comes out of this particular real world study that we are quoting. And the reduced outcomes may be due to a reduced HER2 expression, because it has been seen that after pertuzumab exposure, because it is a dual anti-HER2 therapy, there is a reduced HER2 expression, and the HER2 expressions can at times become nil as well. And that may be the reason for the TDM1 not working as much, because TDM1 is a ADC where the drug antibody ratio is 3.5 is to 1, and the payload also is not as strong as the other molecule or the other ADC that we know, which is called trastuzumab deruxtecan. Next slide. Now, talking about recent advances and especially talking about trastuzumab deruxtecan, which is a blockbuster molecule in this particular cancer and its space. Next slide. So trastuzumab deruxtecan started to come up in about 2018, and after that, it has seen the light of the day, and then there has been no looking back. There have been many anti-HER2 therapies which have been approved after and before trastuzumab deruxtecan, but it looks as if there are a lot of trials which suggest that TDXD is going to, and it has to a certain extent, pipped almost all the existing anti-HER2 therapies to the finishing post. And that is because it is a very robust molecule with a good antibody drug conjugate ratio, which is 8 is to 1, and a payload which is a topoisomerase 1 inhibitor, which is SN38, which increases the efficacy of this particular drug. Next slide. Next slide. So this is what I was talking about. The mechanism of action is that there has to be a drug antibody ratio of 8 is to 1 with a highly potent topoisomerase inhibitor 1 payload and a cleavable linker. And it also not only does it enter the tumor cell, but it also leads to cell permeability, which leads to a bystander effect. And that also leads to a high efficacy. TDXD demonstrated responses to the therapy in 60% of pre-treated patient population with HER2 positive metastatic breast cancer. Next slide. Now, if we talk about Destiny Breast 02, this was a study that we're talking about, which was the randomized phase 3 open label study, where TDXD was pitched against the physician's choice of therapy. And this was in patients who were having centrally confirmed HER2 positive disease. And these patients had received multiple lines of therapy, and they had to have a TDM1 already, which they had to receive, and there was a 2:1 randomization, and the primary endpoint was kept as PFS, with the secondary endpoint being kept as overall survival. Next slide. If you look at the PFS was significantly improved with TDXT as compared to the physician's choice of chemotherapy. One can see that there is a wide gap in the Kaplan-Meier curves, and it was 27%. It was 27% at 12 months and 13.9% at 24 months, and it was a p-value which was very significant, and the PFS was 18 months versus 7 months. So significant improvement is there. Next slide. And the overall survival also was improved in favor of TDXT, and the quantum of benefit was approximately 10 months with a hazard ratio of 0.65. Next slide. So Destiny Breast 02 certainly placed TDXD as one of the options, and a very powerful option in patients who are having a previously treated MBC with TDM1 being certainly there. And it confirmed that the risk benefit profile is in favor of the benefit as well, benefit only in TDXD patients. And this should be an option that should be given to the patients. In patients who were there in Destiny Breast 01, which was a single arm study in phase 2 study of such patients, there also the response rates were seen in excess of 60%. And these were two positive studies, and they paved way for further studies of TDXT. Next slide. Now we're talking about 03, that is patients where the TDM1 in patients who were HER2 positive MBC and already had received first line of trastuzumab based therapy, and many had received even pertuzumab in the frontline setting, and then they progressed, and then they were randomized to either the standard of care, which was TDM1, which we all know was the standard of care till that time, and it was the experimental arm was TDXT. So the TDXT was trying to pave its way up the ladder, and primary endpoint of PFS and secondary endpoint was overall survival. And important to note is that these patients had to have a clinically stable and treated brain metastasis. Next slide. And the baseline characteristics were well matched. There were a lot of patients from Asia, about 60%, and the stable brain metastasis patients were about 30% in both the arms. Next slide. Yes, you've done that. Next slide. So they took the poor prognostic patients, and there were uh, about 30% patients where the patients had 3 or more lines of therapy in both the arms. So 60% of the patients in each arm had received prior pertuzumab as well. So we did understand that a prior pertuzumab exposure, TDM1 doesn't work that much. So what happened to this particular trial, we'll just see in a while. Next slide. And one can see that if you look at the results, the PFS was whoppingly increased in TDXD arm as compared to TDM1. It was nearly 3 times higher. That was say about 8 months versus 28 months. And the hazard ratio also was significant at 0.28. So 72% reduction in the progression or death was reported with TDXT as compared to TDM1. You can see the wide separation of Kaplan-Meier curves and an early separation as well. Next slide. Even the overall survival was higher. This is PFS in key subgroups. In almost all subgroups, be it visceral metastasis or not, prior exposure to pertuzumab or not, or brain metastasis at baseline or not, all of them benefited. Next slide. This is BICR, PFS by BICR, and this also was in favor of TDXD as compared to TDM1. Next slide. And overall survival also was met with the p-value being 0.003 and a hazard ratio of 0.64. Next slide. Yeah, next slide, please. One can say that the crossover to TDXT in the TDM1 was just about 15%, but nevertheless this is a positive study. And then even in ASCO 2024 there was this sensitivity analysis for overall survival. Here also, and the TDXT pipped TDM1 quite comfortably. Next slide. And not only in patients with brain metastasis, patients in without brain metastasis also did quite well with TDXT as compared to TDM1. Next slide, please. Overall response rates also were higher with TDXT compared to TDM1. One can see that in the waterfall plot. Next slide. So TDXD in the dose of 5.4 milligram per kg actually led to all grade pneumonitis of about 11 to 14% in all the trials, and this trial also was no different. We have to take note of the fact that ILD can happen and patients should be counseled about it. And if at all ILD is there, then this is a serious adverse event and patients should be caught early. And if it is grade 1, that discontinuation and restarting once the ILD is improved has to happen. If it is grade 2 or more, then these patients cannot take TDXT anymore, and it has to be discontinuation of TDXT. Apart from that, TDXT is a drug which has got high emetogenic potential, so one has to use the anti-emetic agents accordingly. And there were about 25% patients where the dose reduction also was required in TDXT arm. So if we are able to use TDXT well and choose our patients well, it is a good molecule, but then one has to be aware of the adverse events as well. Next slide. Next slide, please. Next slide. We've discussed this. Next slide. Next slide, please. Next slide. After grade 1 ILD, TDXT re-challenge can happen, but not with grade 2 or more. Next slide. So if we talk about the ESMO 2022 update, the time to definitive deterioration in the patient-related outcomes measures was numerically prolonged with TDXT as compared to TDM1. So the quality of life issues are also not there when we are using this molecule. Next slide. So overall, TDXD is a drug which has improved at least 4 times the PFS compared to TDM1 in the second line in Destiny Breast 03. There was a confirmed response rates, objective response of about 78%. And with longer treatment duration, TDXD continues to demonstrate a manageable and a tolerable safety profile as well. We have to be wary of ILD, and that is what we have to learn over a period of time. Next slide. If we talk about tucatinib, this is another anti-HER2 therapy that we have. We have the HER2 Climb trial, which was a trial of HER2 positive MBC in the second line, which was patients who had been prior treated with trastuzumab, pertuzumab, and TDM1, and they could have had a previously stable treated brain metastasis or an untreated brain metastasis also, which did not require immediate local therapy. So this is something which was different from the DB03, where only the stable and treated brain metastasis patients were taken, and they were randomized 2:1 to receive either a trastuzumab plus capecitabine or a tucatinib plus trastuzumab plus capecitabine based combination. Next slide. One saw that the addition of tucatinib to trastuzumab plus capecitabine resulted in a better progression-free survival and overall survival. PFS was 8 months versus 4.9 months, and median overall survival was 22 months versus 17 months. The common adverse events for tucatinib were diarrhea, as we all know. There was hand-foot syndrome, nausea, fatigue. So it is a drug which is a little difficult to tolerate, and especially for the diarrhea part. But if chosen well, this is a molecule which can give good improvement to our patients in terms of PFS and OS both. And especially for patients who are having brain metastasis, it is an active regimen and a combination. Next slide. Like I said, if you talk about this particular combination being efficacious in brain metastasis population, yes, it is effective, and the PFS was 8 months versus 5.4 months with brain metastasis, and even without brain metastasis, it was about 10 months. So hazard ratio of 0.48 with brain metastasis is quite impressive. Next slide. Even if you look at the objective intracranial responses, it was in excess of 50%. Diarrhea was the most common adverse event, as we all know. Next slide. Talking about neratinib, so we have the NALA trial for neratinib plus capecitabine versus lapatinib plus capecitabine in a HER2 positive MBC treated with at least 2 lines already. So this is a third line trial again, like the HER2 line trial for tucatinib. And neratinib was in the dose of 240 milligrams once a day. Next slide. This trial also improved the overall survival and the PFS in these patients. Sorry, the PFS, not the overall survival. Overall survival was numerically better, but it was not statistically significant. But the main issue is with the diarrhea. Next slide. These patients had significant diarrhea, and the diarrhea, all grade diarrhea in these patients was about 83%, out of which the grade 3 and 4 diarrhea was 25%, which is quite a significant number. That is why these patients had to have a mandatory prophylaxis in cycle 1 with loperamide, and this is something that has to be kept in mind. So neratinib, whether we are actually adding to toxicity by giving neratinib, or this can be for a selected group of patients, probably yes. Again, brain metastasis
Hello.
is.
Sir,
Hello.
please can you conclude your talk in next 2 minutes?
Yes, yes, I'm doing that.
Yeah.
So, especially for brain metastasis patients, because it is a small molecule TKI, so it has got a good penetration into the brain. So, next slide. So, all in all, if we talk about the treatment options, we have a lot of options that we have discussed. The Cleopatra regimen still is the first line option, followed by second line, which is TDXT, and third line we have the options of tucatinib plus trastuzumab plus capecitabine, which is category 1 according to the HER2 climb. And we have the options of neratinib and mirgituximab as well after the Sophia trial, and we have the LabCape option as well. Next slide. And the same has been recommended by NCCN guidelines. The second line trastuzumab deruxtecan has already been included as category 1 recommendation. Next slide. Yeah, so I think that will be all from my side. I would hand it back to Geetika to take it forward.
So thank you so much, Dr. Rajat Pajasa. Moving ahead for the next session, and I would like to invite Dr. Aditya Sarin sir, and he's an associate consultant medical oncologist, Sir Gangaram Hospital, Delhi, and to give us talk about ADCS in HER2 negative and evaluation of HER2 classification. So it's over to you, sir. And this session sponsored by AstraZeneca.
So good evening, everybody, and I'll be sharing my slides now. I hope it's visible. And thank you,
Yes,
organizers,
sir, it's visible.
for having me on such a wonderful platform. I was listening to the previous talks, and I think most of the talk has already been done by Dr. Bajaj, so I'll be able to wrap this discussion very early. So, without wasting further time, so ADC in HER2 negative MBC and evolution of HER2 classification. So the talk will cover the following topic: the historic classification, the structure mechanism of action, which has been fantastically explained by Dr. Bajaj, and followed by that hormone receptor positive HER2 negative MBC and MTNBC, and finally the summary slide. So how historic classification of HER2 and the emergence of HER2 low came into being? So MBC is classified by HER2 expression, which is determined by IHC or ISH/FISH. And HER2 status was previously viewed as binary, like it can be either positive or negative. Earlier, we used to consider positive with 3 plus or IHC 2 plus or FISH plus during my training times, and HER2 negative being IHC 0, IHC 1 plus or IHC 2 plus or ISH negative. And historically, the majority of the breast cancers were classified as HER2 neu negative, as they would not derive any benefit from early HER2 targeted therapies. So what happened that the initial assays developed to detect HER2 overexpressions were calibrated to be in a linear range for the higher end of the HER2 expression spectrum. So antibodies like MDA, MDMB, SKBR, BAT474, they were all being picking up only the HER2 amplified, and the rest all were being tagged as HER2 non-amplified, because these assays were not developed to detect the HER2 low. And if we were to see historically the hormone receptor status, let's say if you have a hormone receptor positive patient, and if you give ET along with the CDK4/6 inhibitor, you can have a good amount of PFS to up till 3 years, maybe slightly less than that, but still, I think most of us are having patients who are running beyond 3 years as well. And for the second line, once you exhaust your initial CDK4/6, or you change the partner drug with the mTOR or PI3A, or you change the ET to a different ET, I think you can derive the maximum benefit for 16 months, and beyond that, the PFS just plummets to only 6 months. If we were to look at the hormone receptor negative, the first line, you can see that the 8 months with the PDL1 with the chemo, it is 8 months in the first line, followed by 6 months with the ADC, and in third line, it's hardly 2 months. So this was the abysmal response in the triple negative, and obviously, as the line progresses, our prognosis goes way down. However, HER2-low MBC has been explored as an actionable population within the HER2 expression spectra. So this was the previous one, and now this is the modified HER2. That HER2 positive still remains the same as discussed earlier, and HER2 null means which is IHC 0, and HER2 low, which is IHC 1 plus or IHC 2 plus dash ish negative. We have to cater it now to as a HER2 low, and 67% of previously characterized as HER2 new negative MBCs are HER2 new low. And one retrospective study investigated the prevalence of HER2 within the HER2 negative population using the MBC samples which have been characterized by HER2 new negative. So you can see the HER2 low resources were available for 787 out of that 600 patients, 529 patients were being characterized as HER2 new negative. And HER2 low prevalence was numerically greater in the hormone receptor positive group as compared to the hormone receptor negative group. And you can just see 52% in the triple negative, and for hormone receptor positive, 71%. So these were those patients who were not deriving the benefit, and we were categorizing them into the HER2 negative subgroup. And the patients with HER2 low disease appear to have different prognosis than those with the HER2 new negative disease. And because you can see the pooled analysis of the 4 prospective neoadjuvant trials reported the decreased PAT-CR and increased DFS and OS in those with HER2 low disease versus with the HER2 negative disease. So it's better to have HER2 low rather than HER2 zero. And following the recent developments in the treatment landscape, HER2 low MBC is now an actionable population within the HER2 expression spectrum. And this was there in Shanu Modi et al., who had a standing ovation in ASCO 22 meeting. And in light of this, what changes do we need to consider in our approach in HER2 new classification and testing? Well, prior to DB04, there was no clinical implication for IHC 1 plus or score 0, leading to the potential misclassification. And now training on low end expression scoring to describe patients' characteristic for HER2 low versus HER2 negative, now it may enable for the reassessment of the previous classification. If we were to see the concordance between the rescores and the historical scores, I think for HER2 new low, positive agreement is to the tunes of 87.5%, and for HER2 IHC 0, now the positive agreement is to the tunes of 70%. And multiple studies have confirmed the wide temporal heterogeneity of HER2 low expression. Therefore, patients should be retested if initially classified as HER2 negative and 0. And I think this is practice changing behavior that we had been following, because we are having patients who we have treated 5 or 8 years back, and at that point of time the biopsy was done and it was either written like negative or 1 plus, and we never used to really care about the further numerical value attached to the HER2 till the time it is being tagged as HER2 negative. But now if we come up and we inquire about the previous biopsy, and I think most of them used to have either 1 plus or a 2 plus with fish negative report. So it's better to do a repeat biopsy whenever in doubt, and always confirm with the initial biopsy as well. The reason for the wide temporal heterogeneity is multifactorial. It's not just one answer. You can have analytical factor, you can have HER2 spatial heterogeneity, you can have a biologic evolution of the disease, and you can have a selection of the clone as well. So how about ADCs in HER2 negative MBC? Well, I think Dr. Bajaj has rightly said that we have an antibody, we have a linker, and we have a payload. The antibody makes sure that it binds to a specific receptor. The linker makes sure that the drug is only cleaved. The linker is only dissolved at a particular point with the particular time and pH, and the drug, the payload, is to be delivered intracellularly, not extracellularly, and ultimately leading to a bystander effect. Because once you have the SN38 molecule being delivered inside the cell, it can definitely go into the nearby cell without the need of the antibody drug receptor assembly. So he has rightly said that the drug antibody ratio is to the tunes of 8:1, and the payload being deruxtecan, and obviously it is the deruxtecan molecule. It is a topoisomerase 1 inhibitor. For SG, which is govitican, it is SN38, again a topoisomerase 1 inhibitor. So early ADCs, such as the TDM1, have a non-cleavable wrinkle and low membrane permeability. This results in the target cell intracellular payload release and toxicity, ADC binding to the receptor, internalization by endocytosis, and the payload release after the linker is cleaved by the lysosomal enzymes, and again, cytotoxic effect induced by the drug payload. Whereas the bystander effect, it is observed in the govitican, and you can see it in the TDXD. What all different mechanisms are there? That release of drug payload from the antibody after antigen binding before internalization, release of drug payload into the intercellular space due to the high drug membrane permeability, and highly membrane permeable payloads intracellular space enter neighboring cells, delivers the cytotoxic effect leading to the cell death. So how about the data? In the hormone positive HER2 negative MBC, the treatment landscape, we all know it is AI or fulvestrant with the CDK4/6 inhibitor, and then you have multiple number of options. So if your patient is not a candidate for ET, you go for HER2 low testing, and I think everybody will agree that TDXD is the way to go, or you can go for SG or a PARP if you have a germline BRCA mutation. But if a patient is having a further ET, I think you can choose the partner drug. But because for the sake of discussion, I will be focusing this particular subgroup only, not a candidate for further ET. And we are supposed to give TDXD along with the, or with the SG. So the emerging data indicates that the post-CDK4/6 inhibitor ET or ET-based regime results in poor outcome for patient. There is no clear second-line standard of care which can fit everyone following the first line CDK4/6 ET, and patients with relapsed disease have ongoing unmet needs. With DB04, you can see that the trial was randomized into the 2:1 ratio with TDXD 5.4 mg per kg Q3 weekly versus the physician choice chemo, and the primary endpoint being the PFS by BICR and the secondary being OS on the hormone receptor or the OS in all the patients. So groups were well matched, and Asian population constituted approximately 40%, and obviously the inclusion criteria had to be 1+ or 2+-ish negative subgroup. All the patients had good ECOG status. Hormone receptor mostly, obviously 99 had good hormone receptor positive status. Most of the patients had either 3 lines or 2 lines of therapy. And I think these were all, the settings were all well matched between the hormone receptive and all the patients in where even hormone receptive versus hormone negative subgroup if we were to see. So again, it was a well matched trial. And this was the reason for the standing ovation, the doubling of the PFS with the hazards of 0.51 at the end of 12 months. So you can just see that the PFS being 10.1 months in the experimental arm and the delta of 4.7 months. Whereas the key secondary endpoint in the hormone receptive OS, it was, if we were to see, that there was a delta of 6.4 months. And TDXD did improve PFS and extend MOS in patients with HER2 positive, hormone positive, HER2 low MBC. You can just see in the hormone receptor subgroup, the TDXD in the updated analysis gave a 9.6 month Whereas in the physician choice, it was 4.2 months. And again, the hormone receptor cohort did a better benefit to 24 months vis-a-vis 17.6 months. Again, you can just see the hazards of 0.69 over here. And if we were to see the ORR, it just tripled with the HER2 in the hormone receptor positive as and compared to the TPC, which is the treating physician choice. And if we were to see in the hormone receptor negative, it was again 50%, and in the other arm, it was only 16.7%. If we were to see the tornado plot, you can see the majority of the TDXD adverse event DB04 were mostly grade 1 and grade 2, other than the nausea. I think nausea constituted 4.6, then 7.5 being the fatigue, neutropenia, anemia. So these were the major issues. And obviously with chemo, you are bound to have more neutropenia. So maybe that's the reason that these subgroup had more neutropenia and leukopenia. And what about ILD and pneumonitis? So yeah, patients who had, approximately, including the grade 5 diseases were reported with the TDXT DB04, and the majority were grade 1 or 2. And if you have a grade 2, Dr. Bajaj has rightly pointed out, you need to switch it off. Switch the NHER2. You're not supposed to re-challenge it. With the grade 1, it's okay, but not with the grade 2. And it was there to the tunes of 6.5%. Adding to the fragmented second-line space in the hormone receptor positive MBC, there is a role for the TROP2 targeted ADC in endocrine refractory patients. So this was the TROPICS trial where sacituzumab govitecan was given versus the treatment of physician choice. And let's see at the end of 12 months, the 12-month PFS rate is to the tunes of 21.3% as compared to 7.1%. And the key secondary endpoint was the OS. Again, if we were to see, the median OS was there to the tunes of 14.4 versus 11.2 in the physician's arm, and with the hazards of 0.79. And you can see the graphs, they start to separate after 3 months of the initiation of treatment. So you need to give at least 3 to 4 doses before going for a re-evaluation. And this was proven irrespective of the TROP2 testing. Even patients with less than 100 TROP2 subgroup, more than 100 TROP2, less than 10 subgroup of the TROP2 testing. Because now we are going to get ADCs where TROP2 might be mandatory. Like for, I think, datopotamab, it's there that you have to go for a TROP2 testing. Otherwise, you will not be able to give the ADC over there. But for SG, which is govitecan, it's not required. It has shown benefit in all the subgroups. Especially, and also if we were to see the PFS, irrespective of the HER2 low or HER2 zero, the PFS benefit was there, and as well as for the OS. What about the side effect profile? Well, neutropenia, diarrhea, nausea, again, the run-of-the-mill side effects, again, were mostly well matched and was well balanced and manageable. The neutropenia, diarrhea, nausea were the most common SG-related adverse event. Well, I think everybody can manage these. What about TNBC landscape? That the TNBC landscape, it is multifaceted with ESMO NCCN guidelines showing it is rapidly evolving. And we were to see that patients with HER2 low, the second line, now we have TDXD as an option, or sacituzumab for patients with any, that the marker need not be there. If you have the ability, you can choose it. And if you have not used sacituzumab in the previous line, you can definitely use it in the third line. Now coming to DB04, again, I think this we have discussed, and it has improved in the patient, the PFS and OS in triple negative, where the HER2 is low, and efficacy in the hormone receptor negative cohort was an exploratory endpoint, and you can see the PFS benefit of 8.5, and with a delta of 5.4 months. And for OS, it is even way higher, 10 months of delta. Again, it tripled the CORR and 52.6% in hormone receptor. And in the previous slide, I've already shown regarding 50% benefit in the hormone receptor negative. So this was the Accent trial, where phase 3 trial investigating the SG versus the treatment physician choice, where triple negative breast cancer, more than 2 chemotherapies or 2 lines of chemotherapy for advanced disease have been taken. And we were to see the secondary endpoint. You can see the PFS benefit of 4.8 versus 1.7 month with the hazards of 0.43. And for all the patients, if we were to say that you can have the median OS of 11.8 versus 7.9 months, and again hazards of 0.51. So definitely, if we were not to see this IHC 0, 1 plus, 2 plus ish negative, this drug also has role. But considering the data over here, I think everybody is more comfortable using with a delta of 10 months. Obviously, cross-trial comparison we are not supposed to do, but for the sake of this platform discussion, we can just see the data again. And the most common side effects being neutropenia, diarrhea, and nausea, again, well managed. So the summary slides are on now. So DB04 established HER2 low MBC as an actionable population within the HER2 expression spectra. We have the approval in HER2 positive, hormone positive, HER2 negative. For the second line, you can use for deruxtecan. If the patient is not a candidate for deruxtecan, go for govitecan. For what about the triple negative? I think if you have a BRCA, go for the PARP inhibitor. Otherwise, you can go for sacituzumab. So if you don't have any BRCA mutation and your profile is coming under HER2 low, go for deruxtecan. So I think I have covered most of the discussion, and I thanks my organizing team. Thank you, and back to you.
Thank you so much, Dr. Aditya. Okay, so moving ahead for the next session, and I would like to invite Dr. Priya Tiwari, and she is a senior consultant Department of Medical Oncology program, and this session is sponsored by Novartis, and she is talking about evolving evidence for the multiverses of HER positive, HER2 negative ABC patient. So it's over to you, ma'am.
So I'll just start sharing my screen. Am I audible?
Yes, ma'am.
Okay. So there's some problem with the video. From my side, I'll just start sharing my screen. I think I initially requested for the slide to be run by the organizers, but I'll run my own slides.
If you want, so I will.
No, I'll be comfortable doing it. Thank you. Thanks a lot.
Okay, ma'am, can you please open your video?
Yes, I can, but the video quality is very bad because the lighting here is very bad. So
Okay,
I'll just
ma'am.
do it. No worries. Okay. Just a minute. So, very important point of discussion that we need to that this topic has been given to me, that we are all aware of how the treatment landscape of metastatic breast cancer is evolving, and HR positive breast cancer is no exception. The key consideration for first line treatment decision making for whenever a metastatic hormone positive breast cancer comes to us is the impact on the quality of life, the survival, how long are the patients going to live, what are the site of metastatic disease, how aggressive is the disease, is there presence or absence of any visceral crisis, what are the patient expectations and the goal of their own goal of the treatment, and what has been the previous treatment responses. Like there is now evolving data of CDK inhibitors in the adjuvant setting. Okay, so it's not just that now the terms are being limited to whether it is a hormone sensitive disease or hormone resistant disease, but down the line it's also going to be CDK inhibitors exposure in the adjuvant setting or not. So currently the guidelines, the ESMO guideline, the NCCN guideline, they uniformly recommend that whenever you have a first line metastatic disease, then the treatment choices are decided by the combination of endocrine therapy with CDK4/6 inhibitors. So we have three CDK4/6 inhibitors: abemaciclib, palbociclib, and ribociclib. If the patient progresses on any one of them, then the subsequent choices will again be decided if the patient has presence or absence of visceral crisis. What are the other genetic abnormalities, such as presence or absence of PIK3CA, and or the BRCA testing revealing a positive BRCA, and so on. So these are this is how the treatment option is going to evolve. Importantly, because of these number of options that the patients have available, which are very effective, in most of the patients the chemotherapy is actually pushed to third line and beyond. So, like I said, that we have three CDK4/6 inhibitors. So, this is the slide to show the data in terms of the PFS. And because of their remarkable PFS demonstration with an HR ratio, a very convincing HR ratio of 0.56, 0.58 and 0.54 for all of these three drugs, that is the ribociclib, palbociclib and abemaciclib, they became the standard of care. And we knew that if you give this patient, in addition to the usual conventional hormonal therapies, the patients are going to do better and for a longer time. But yes, the data regarding the overall survival have somewhat been conflicting, especially regarding, you got two studies, that is the ribociclib was the which very convincingly showed a positive impact on the overall survival. Not so much with palbociclib, and that is a problem. Some people say there's two schools of thought. Some people say that these three CDK4/6 inhibitors are same, you can use them interchangeably, there is not much difference from one, and if you get a difference in the overall survival data, that might be because of the trial design, the impact of crossover, and yes, something to do also with the endocrine resistant, subsequent resistant pathways, what have been the last, when most of the patients were either de novo metastatic or patient who progressed after the adjuvant therapy. So all these factors needs to be taken into consideration while analyzing the overall survival data. But yes, till now we have the most strong impact on the overall survival data is from the ribociclib, followed by to some extent abemaciclib, but not so much from the palbociclib. The other group of the authors say that there is some difference between the molecules. The ribociclib has a more affinity compared to the palbociclib for the inhibition, and that might be causing it to become more effective. Also, abemaciclib has an off-target activity on CDK9. So, other school of thought says that the abemaciclib might again be a more effective drug compared to palbociclib because of its off-target activities on CDK9 inhibition, also imparting it as a better CNS penetrating CNS agent, and also as a single agent activity. So, what are the side effects of these drugs? Now we are well versed, and we know that all these drugs can cause neutropenia, thrombocytopenia, but the incidence of febrile neutropenia is less, hence these side effects are not bothersome. Also, diarrhea could be a problem and a challenge with abemaciclib. Abemaciclib has also been shown to cause pulmonary thromboembolism. Ribociclib has some impact over the QTC prolongation, and that is why the European guidelines don't recommend using ribociclib with the tamoxifen, where the incidence of QTC prolongation could be higher. But having said that, most of these drugs are fairly these are easy drugs to use, and we are now well versed with how to use these drugs. You can lower down the doses, and that also gives an advantage to ribociclib, where you have a 200 milligram strength. And so dose tweaking is very easy because patient buys 200 milligram, you can give 3 tablets to start with. If they side effect, you can decrease to 400 milligram. So overall, also, if the studies are there, all these three drugs have shown that they maintain quality of life. Also, especially ribociclib has shown there is a clinically relevant improvement in the pain score. A lot of these patients will have bone metastasis, and we also know that we need a rapid response. Initially, we thought that the rapid response could be achieved only by chemotherapies, but with these data coming up, especially with the ribociclib, we know that the early responses could also be possible with CDK4/6 inhibitors. So if again to summarize the key data from the major trials, so you have a Mona Lisa 2 trial where the population was mostly postmenopausal. It was a first line setting where the endocrine therapy partner as well as the comparison arm consisted of letrozole, and it did show the positive impact on the PFS, OS and quality of life. So overall MCBS agent score was 4. And similarly, you also have premenopausal data of Mona Lisa from Mona Lisa 7, and you also have Paloma 2 study for the palbociclib in postmenopausal female, and you have again a comparator arm as well as the combination arm of letrozole, and where it has shown a positive impact on the quality of life and PFS, which were the main outputs reported till date. However, because of the lack of clarity and the OS data not reported, the ESMO MCBS agent score is around 3. And on the similar line, because of the lack of OS data, abemaciclib has also been given a score of 3. So, like I said, that the ribociclib has certain advantages over especially palbociclib. It's a highly selective CDK4/6 inhibitor leading to less off-target dose-limiting toxicities. So, some off-target activities can impart efficacy, but some off-target activity can also cause a lot of side effects. 8-fold difference in the activity on CDK4 of ribociclib versus palbociclib, and abemaciclib has a 5.5-fold activity. And yes, it achieves a high level of exposure in plasma compared to all CDK4/6 inhibitors that you can see from these tables. So overall survival benefit across all studies, quality of life maintained improved across studies, and the efficacy across different difficult to treat metastases, and that we will see subsequently. So how do we want to make the life easier for our HR positive patients? What evidence do we have with CDK4/6 inhibitor for the multiverse of HR positive, HER2 negative advanced breast cancer patients? From the Mona Lisa 2, what was seen that yes, the median overall survival with ribociclib plus endocrine therapy compared to endocrine therapy alone in HR positive metastatic patients with bone only met favored the ribociclib combination 72.6 versus 56.4. So median overall survival for 6 years with ribociclib plus endocrine therapy with bone only metastasis. So sometimes people say that if you have just bone metastasis, maybe single agent hormonal therapy is the best way to go forward. However, in this particular group also, you see a clear cut advantage of addition of this agent. So until unless patient is very frail and you see that the compliance can also be an issue, maybe the combination is the best foot forward even with the patient with bone only metastasis. The second group is elderly. So I'm talking about patients who are frail, but however, the frailty is not just decided by the age. So you have a patient who can, you feel that the patient can tolerate a combination therapy. There is data to suggest that yes, in this group of patient also, that you see a higher, you see a patient living longer with the use of combination therapy. So between 65 to less than 75 years, you see an HR of 0.79. More than 75 years, you see an HR of 0.75. However, we also understand that these drugs can cause more toxicities and more problems in elderly, especially more than 75 years. Keeping them in regular follow-up might be a challenge. They might be on polypharmacies, risk of drug interaction might also be there. Hence, you have to choose your options judiciously and with caution. But however, if there is a if there is a patient who is old but fit and is willing and is compliant, maybe the combination is the best foot forward based on this data. So what about the other parameters? So MTCCC in elderly patients is again a very important parameter. We have to see, okay, that if nobody wants, these kinds of treatments such as chemotherapy, especially in elderly, the family comes and they ask us, Madam, लगता ही नहीं कि patient chemo tolerate कर पाएंगे, क्या करना चाहिए? So we know that we have a very effective option to offer to these group of patients, and this was also seen that MTCCC was delayed across all age groups, is also in elderly with the use of this drug across all the Mona Lisa trials. So yes, the various endpoints, the PFS, the overall survival, as well as the time to chemotherapy was also delayed. Now, what about patients with liver metastasis? Liver metastasis is one of the sites where we know that the patients could have had very aggressive disease biology, and it's not just that these patients have aggressive disease biology. Liver metastasis also tells that the subgroup of patient might have inherent endocrine resistance. Okay. So from the trial, it was seen that patients who have liver metastasis, again the combination therapy is a better choice. 29% relative reduction in the risk of death was observed in ribociclib plus endocrine therapy arm in patient with liver metastasis. And if for all the visceral metastasis also, that the combination did better. So now the data, there is some data, especially from Dr. Shaina Daud, that for patients who are in visceral crisis also, not just patients who have visceral disease, but in visceral crisis also, maybe you can use this drug because they have a very rapidity of response. However, in visceral metastasis, yes, the combination does better. So across all the major subgroup, also in the patients who have visceral disease, this option does better compared to hormone therapy alone. Now, what about the CNS metastasis? This we have seen that, see, the hormone receptor positive breast cancer is not one of those diseases which goes in the brain metastasis, but we know that a subset of patients will present with CNS metastasis, and CNS metastasis is also very common down the line. So this was the subgroup analysis as a part of the complement real world evidence. So let's see that from the various analysis, because there are fewer patients who will have CNS metastasis, so number of patients from each trial were taken, and it's actually quite small. Also, because CNS metastasis is excluded from various trials, from each trial it's not possible to have the patient with CNS metastasis. However, from the trial that we were able to find certain problems, certain CNS metastasis patient, this data was calculated. So phase 3B real world study including 51 patients with CNS metastasis. Also, abemaciclib has a phase 2 non-randomized study in HR positive, HER2 negative patients with CNS metastasis, where the 5% patients were confirmed responders with the primary endpoint of intracranial overall response rate of 5.2% and secondary endpoint of intracranial disease control rate of 25%. So again, the brain metastasis becomes a very difficult site to have for the disease, because for the patient, because this is the site we know that most of the hormonal therapies, they don't penetrate the brain, and effective treatment options are quite limited. So, diverse large population with subgroups more representative of real world practice and not well studied in CDK4/6 inhibitors. So, this included patient treated with prior chemotherapy for advanced disease, patient with ECOG performance status 2, patient with stable serous metastasis, premenopausal status diverse range in age compared to the other premenstrual. Okay, so we do see that a patient who had were given these drugs had this trends towards longer time to progression versus overall population. So this is prolonged time to progression in overall population, M27.1 and MTTP not reached for the patient with CNS metastasis. So again, that the patient with CNS metastasis had a trend towards longer time to progression versus overall difficult to treat population. Now what about patient who had multiple metastatic sites? Patient who had multiple metastatic sites, the 3 or more metastatic site, again the combination does better. So 27% relative reduction in the risk of death with ribociclib plus endocrine therapy in patient with 3 or more metastatic sites. Now, right choice, again, very important study. Like we keep talking about the patient with visceral crisis, there is also a group of the patient which is now being labeled as an aggressive disease. So, what is aggressive? So, it means patient who has symptomatic visceral metastasis, rapid progression of disease or impending visceral compromise, markedly symptomatic non-visceral disease. So, this is a group of the patient labeled as aggressive disease, and we wanted to answer whether we should use these kinds of therapies in compared to chemotherapy in this group of population. So this was the right choice study done to answer this question. So I would just want to highlight here that this does not mean that the patient has visceral crisis. Okay, this is the definition uses the aggressive disease for the aggressive disease. So this was a prospective study comparing CDK4/6 inhibitors plus endocrine therapy versus combination chemotherapy in advanced cancer, breast cancers. Okay, so ribociclib plus non-steroidal aromatase inhibitors were taken plus goserelin and investigated choice of combination chemotherapy. So, visceral disease is a big term, aggressive disease is again a big term, and a part of aggressive disease could be visceral crisis too, which was left to the clinician decision to decide and take into study. Okay, but aggressive disease does not always mean visceral crisis. Okay, so the primary endpoint was PFS with number of secondary endpoints. And when they found that yes, so we are using a chemotherapy arm here, and traditionally we've always believed that that maybe the chemotherapy is the best foot forward when the patient has lot of disease, lot of visceral disease. Okay, so you see the combinations here: docetaxel plus capecitabine. So it's not just a single chemotherapy was used. Combination chemotherapies were also one of the options: paclitaxel plus gemcitabine, capecitabine plus varorelbine. 1:1 randomization, and we do see the hormonal therapy does better. So whenever you see an ER positivity, the hormonal therapy is the best foot forward. Statistically significant PFS benefit of 11.7 months. So one of its kind study with motivation and courage to do a hormone versus chemotherapy comparison in an early line of setting in a patient subgroup supposed to do poor on the hormonal therapy. So we do see a median PFS of 24 versus 12.3, which a convincing HR of 0.54, and you can also see it by the separation of the curves. So 2x PFS benefit over combination chemotherapy in clinically aggressive HR positive disease, and we also see a difference in the overall response rate as well as clinical benefit rate with the favoring ribociclib options. So what about the Asian versus non-Asian? So post-hoc analysis of the Asian and non-Asian patients from these right choices study also shows that for the Asian patients you have an HR of 0.48, for non-Asian patients you have an HR of 0.85. So yes, maybe ethnicity also plays some role. And overall, again, when you see the other end points, we do see that TTR especially is better in Asian patients compared to the non-Asian patients. See, the guidelines say, what the guidelines say is that and now how are they modifying the statement based on the evolving data? So in the right choice trial, the combination of ribociclib plus aromatase inhibitors, okay, so, plus LHRH agonist in premenopausal females were compared to the combination chemotherapy as first line therapy for perimenopausal females with ER positive HER2 negative metastatic breast cancer with clinically aggressive disease, which was defined as symptomatic visceral metastasis, rapid disease progression or impending visceral compromise, markedly symptomatic non-visceral disease, but with bilirubin less than 1.5, therefore not in liver visceral crisis as defined by the ABC guideline. The endocrine therapy plus CDK4/6 inhibitor yielded a 12 months benefit in PFS with a similar overall response rates and similar time to onset of response in both arms, but substantially better toxicity profile. So these results reinforce the place of endocrine therapy plus CDK4/6 inhibitors as standard of care for first line therapy for the majority of patients with ER positive and metastatic breast cancer, including those with clinically aggressive disease. So the trial was performed only in the pre or perimenopausal females. The panel believes that the results can also apply to the postmenopausal females and men with the same disease characteristics. So what about ET resistant population? So we are all jittery to use these whenever you see, the patient had received adjuvant therapy and patient has progressed during the adjuvant therapy or just immediately after stopping the adjuvant therapy. So in most of these trials, patients have been, there have been a population of endocrine therapy resistance. So there has been there's some difference in the endocrine therapy resistant definition. So progressive disease within 6 months of first line
Ma'am,
endocrine.
can you please conclude your talk in next 2 minutes?
Yes, sure, bilkul. So this is what the definition has been given, and we now know that the overall survival benefit in patients with endocrine therapy resistance was not in the same range across CDK4/6 inhibitors in the phase 6 trial. But we do see that because that this slide tells you that we do see a difference by certain CDK4/6 inhibitors, especially the abemaciclib and from the ribociclib, that even in the ET arm the resistance is actually somewhat overcome. So I think there has been an ease to use and not worrying whether ribociclib would be effective in a low burden or high burden patients, and ease in explaining overall survival to the patients, and ease in titrating doses as per the clinical status. And overall it makes your life simpler to choose what particular drug you want to give to the patient. So that will be all. Thank you.
Thank you, Dr. Priya, uh, for the exciting talk. And moving ahead for the next session, and this session sponsored by AstraZeneca. And I would like to invite Dr. Ankit Batra sir. He is an associate professor, Department of Medical Hemato-Oncology and BMT, Cancer Research Institute, HIMS, Dehradun. So it's over to you, sir. So Dr. Ankit Batra sir.
Yeah, just a second. I'm sharing my screen.
Sure, sir.
Yeah. Is it visible now? Hello.
Yes, sir,
Yes,
it's
sir. Yes, sir.
visible.
Okay. Okay. So, very good evening, and thank you, AstraZeneca and Dr. Rajat Bajaj, for organizing this webinar and having me here. So, I'll be discussing about the updates in the BTC with respect to the Topaz 1 trial. And we all know that durvalumab plus gemcitabine cisplatin is the new standard of care for first-line advanced BTC. So, just a brief about the stats, and we know that the burden of the disease is quite significant in our part of the world, especially in the North India. And this is a comparison map of the world and showing that the highest incidence of the gallbladder cancers as well as the gallbladder disease stones is prevalent in our part of the world. So, the disease burden and the problem is basically from where we are practicing, and we have to find better solutions for that. A brief about the stats. We all know that almost above 30,000 cases of BTCs, including the gallbladder, have been diagnosed every year. And the crude incidence of gallbladder and BTCs in females are highest in Assam and Delhi. But the unfortunate part is that 90% of these BTCs are diagnosed in a very advanced, unresectable stage. And that time, most of the patients are just in the palliative setting. So that is a very huge unmet need, how to diagnose them earlier and how to make the treatment of this unresectable state better and to increase the survival rates. If you see about the survival rates that are very dismal, and the median overall survival is less than a year with a 5 years overall survival rate of less than 10%. But the trends of the disease are increasing day by day, and both in males as well as the females. What we know about the current management, if we see the NCCN guidelines 2 years back, that is in 2022, the gemcitabine cisplatin was the category 1, and rest other were either second line or other recommended, and were category 2B. So what has changed now, we'll discuss in the later slides. Till 2010, there was no proper standard of care, and different permutation and combinations of chemotherapies were practices. Then came the ABC-02 study, which had shown marginal benefit in PFS and OS with the combination of gemcitabine and cisplatin. And then that time it became the standard of care for locally advanced or unresectable and metastatic BTCs cancers. So gemcitabine cisplatin continues to remain the standard of care in this arena for the next 1 decade. If we talk about the other regimens and their comparison head to head with gemcitabine cisplatin, so they were fairly comparable, but because of the higher EFS, potentially lower cost, lower incidence of peripheral neuropathy and hepatotoxicity, that favors the use of gemcitabine cisplatin as compared to Gemox. If we talk about the role of maintenance, because many of us has seen that in a clinical practice, once the patient, there is a chunk of patients who responds very well, even a very good response, but we all know that that response is very short durable and the disease will come back very quickly. So what is the role of maintenance gemcitabine? And here we have some evidence from our country which only showed that there is a marginal PFS benefit and no statistically significant OS benefit. So the maintenance gemcitabine is of very minimal use and not practically used everywhere. And what about the real world evidences for the continuation of chemotherapy, whether that adds anything in terms of survival or not? If any kind of chemotherapy which we are using in the first line that can be continued beyond 4 to 6 cycles or not, will that help? Will that only add to toxicities? So the answer to that is from the publication which we can see from the Tata group, that in this study the OS appeared to be lower than the published literature, but survival can be prolonged. But still, practically, we all know that continuation of chemotherapy adds only to toxicity rather than improving the overall survival. So we have a huge unmet need, and we have seen with different permutation and combinations of chemotherapy, there is just a few months here and there, and we are not able to decrease the survival, whether PFS or OS significantly. And in the arena, in the era of immunotherapy, whether immunotherapy addition will add anything great to this in the first line settings of advanced BTC or not, we'll see in the further slide. We have a phase 3 randomized double-blind placebo-controlled study of durvalumab in combination with gemcitabine and cisplatin in patients with advanced BTCs. That is the Topaz 1 trial. And here, all the patients with locally advanced or metastatic BTCs, that is intrahepatic cholangiocarcinoma or extrahepatic and GBCs, were included. Patients who were untreated, if unresectable or metastatic at initial diagnosis, or they have a recurrent disease more than 6 months after the curative surgery or adjuvant therapy. And they were randomized 1:1 into two arms, that is durvalumab 1500 milligram every 3 weeks plus Gemcids up to 8 cycles as compared to placebo plus Gemcids. And in the maintenance, placebo versus durvalumab was continued every 4 weekly. So the primary objective here was overall survival with various other key secondary objectives. If we look at the baseline and the demographic characteristics, they were very well matched in terms of age, sex, race, religion, the performance status, the type of tumor, that is ICCA, ECCA or GBC, and the disease status. And majority, almost 80%, were initially unresectable. The disease classification, whether locally advanced or metastatic. In terms of precision medicine era, biomarkers were also seen, but the records were not that great, and it was missing. That is, the MSI status was missing in almost 50% of the patient because it was not planned initially. And if you see MSI high, that was less than 1% in both the groups. Virology status was also seen, and that was comparable, and no viral hepatology was seen in more than 50% of the patients. The PDL1 expression was looked in terms of TAP, which was more than 1% in almost 60% of the patients, whereas it was missing in around 10% of the patients. If we talk about the responses and the continuation of the uh, patient disposition, then ongoing treatment at the time of evaluation, it was almost 20%, 18.6% in the durvalumab arm as compared to 6% in the placebo. And if we talk about the discontinuation rates due to various reasons, because of progression, it was 56% in the durvalumab arm as compared to 70% in the chemotherapy alone arm. And if we talk about the subsequent anti-cancer therapies, so almost 5% of the patients have received immunotherapy in the Gemcis arm, which was not a very great crossover. So coming on to the primary outcome, that is the overall survival. If you look at this Kaplan-Meier curve, we can clearly see that the median overall survival is just marginally increased, that is 11.3 versus 12.9. But if we look at long term, that is 2 years, then the overall survival is doubling, which is 11.5 versus 23.6%. So there is a separation of curve after 6 months, and though all those patients who have been able to continue for the initial 6 months and are responding have a good, we can also see a tail at the end that yes, the durability of the response, as we commonly see the phenomena with the immunotherapy, is seen here also. And so all those patients who do not have that major logistic issues should be offered durvalumab in combination with gemcitabine, because here we have, after so many decades, something which is increasing or doubling the overall survival at 2 and 3 years. If we see the subgroup analysis for overall survival uh, in the forest plot, we can see that the overall survival benefit was seen favoring the durvalumab plus gemcitabine cisplatin across all major subgroups. And although the unity was clear, but the star was on the left of the unity. If you see the PFS curves, we can clearly see that the PFS curve separates around 6 months. And if you see at 1 year, it was 25% versus 35%. At 12 months, it was 6.6 versus 16. So almost the PFS was tripling. If you see the median PFS, it was 7.2 versus 5.7. So yes, there is a good benefit, although the quantum is not that great. But yes, we have something to offer over and above chemotherapy. Similarly, if we see the forest plot for the subgroup analysis for the PFS, we can see that the same data has been replicated, what we have seen for the overall survival. The important thing is the overall response rates and the durability of the response. And here also, increment has been seen, that is 18.1% with the gemcis versus 25% with the addition of durvalumab along with gemcitabine and cisplatin. And gemcis has also showed a significant superior overall response. That is, one into four patient remaining in response beyond 1 year. So that is also very important. Now, the patients who have responded continue to respond. What we see with the phenomena with the immunotherapy, and they continue to respond better and beyond the second year. And among responders, there was a clear and sustained separation of the curve. We can clearly see in this Kaplan-Meier curves, and the curves beginning approximately 15 months after the randomization. And similarly, among the participants with the best objective response of stable disease, there was a sustained separation of the curves at approximately 6 months later as well. Now, the addition of durvalumab to gemcitabine was well tolerated, and it did not add to any extra safety or toxicity issues. If we talk about any adverse events, it was comparable in between the two groups. Any grade 3 or grade 4, then also durvalumab plus gemcis did fairly well. Any adverse event leading to discontinuation was less in comparison to the gemcis arm, and leading to death was also very well comparable to the gemcis alone. So durvalumab addition did not lead to any major grade 3 or grade 4 side effects or discontinuation or death. If we talk about the adverse events related to the immunotherapy, then definitely they would be higher, and that was well expected, both in any types of adverse events and also in grade 3 and grade 4. If we talk about other toxicities, in that case, the chemotherapy related toxicities, especially the anemia, neutropenia, and the decreased ANC count, was numerically higher in the gemcis arm as compared to the durva gemcis for unknown reasons, but that we can say that it is fairly comparable. Specifically talking about the immune mediated adverse events, so grade 3 or more adverse events were seen in around 2.4% of the patients, and majority of them being rash or hepatic event, pneumonitis, and diarrhea, colitis, and thyroid related events. So that is what we see in all the settings, and we have learned how to catch them early and manage them. So not a big deal with that. Now, what is the effect of mutation on survival on the outcome? So this was a post-hoc analysis of the Topaz 1, and they have looked into the genomic alteration landscape of the BTCs of all the patients who have participated in the Topaz 1. So TP53 was seen around 50% of the patient, followed by CDKN2, KRAS, ARID1, SMAD4, and various others. If we talk about the targetable mutations, then KRAS was the most common, which was around one-fourth of the patients, followed by IDH1 and ERP2 amplification, and followed by BRCA1 and 2, which was around 4% of the patients. Then BRAF and FGFR, which was seen in around 3 to 4% of the patients. If we see the genomic alteration according to the landscape by the primary tumor locations, then also we can see that in the if we talk about the TP53, it was most common in the gallbladder, followed by cholangio. If we talk about KRAS, then also it was most common in the extrahepatic cholangiocarcinoma, followed by intrahepatic cholangio, and then the gallbladder. If we talk about the IDH, then it was mainly seen in intrahepatic cholangiocarcinomas, and ERB2 amplification was most commonly seen in the gallbladder as compared to the cholangio, which was almost one third of that. So just a post hoc analysis of what was the impact of this genomic alteration on the overall survival. So here also it did not have a decremental effect, especially in terms of TP53, which was very common. And the results were fairly comparable between the wild type and the altered type. Similarly, it was favoring the wild type CDKN2A and B and MAP loss as compared to the alteration. In terms of ERB2 amplifications, the wild type had better results as compared to alterations. We all know that there is a target and it responds to the uh, targeted therapies better. In the second line, we have evidence for that. What about the real world evidences? We have two studies, one from the Italy, which was by Margherita Rimini et al. And durvalumab plus gemcitabine cisplatin in the advanced BTC. This was an exploratory analysis in terms these are the demographic and the disease characteristics. More than 60% patients were intrahepatic and the GB cancers were very less than 15%. If we talk about previous surgery, so almost 70% did not have any surgery, and other parameters like liver profiles were also normal in 50% of the patients. So these are the survival curves from the real world evidences from Italy, and the median overall survival was 12.9 months versus 8.9 with the Gemcis alone arm, which is fairly replicating what we have seen in the Topaz 1 trial. If we talk about the overall response rate, so stable disease was seen in 53% of the patients, and progression was seen in 12.4% of the patients. Around 5% had complete response and partial response in 30% of the patients. This was about the side effects, which was almost like mainly due to the chemotherapy component and less likely to the immunotherapy and fairly comparable to what we have seen in the Topaz 1. When we talk about the real world evidences, we have studies from India as well. And this was a collaborative study from 11 centers, which was published last year. These were the participating centers. If we talk, there were 75 patients were included in the from February 22 to January 23 with a median age of 60 years, and almost like 43 were male, 43% were male and 57 were female. In terms of site specific, here the things are different, and almost like 60% of the patients were gallbladder, and all 35% were intrahepatic cholangiocarcinoma. Extrahepatic were very rare. The median follow-up of this study from India was 4.9 months. Median cycle of durvalumab was 4. Median cycle of chemotherapy was 5. Almost 42 patients out of 75 progressed on the first line, and there were 26 deaths reported. These 10% were treatment related and 76 were disease progression related, and 31 out of 75 are alive on treatment and doing good. And if we talk about the overall survival curves, then here it was for gallbladder 8.4 months, and for cholangio it was 14.2, and overall it was 9.7. So it has also shown that the survival rates are better in cholangiocarcinoma as compared to GBC, and almost replicating what we have seen in the Topaz 1 trial. In terms of PFS, it was 5.2 months for the gallbladder and 6.2 for the cholangio, and overall it was 6.1 months. Similar toxicity profile were also seen, and dose reductions were seen, especially for chemotherapy, in around one-fourth of the patients. Durvalumab was discontinued in around 7% of the patients. Grade 3 and grade 4 immune-related adverse events were seen in 13% of the patient, most commonly being the hypothyroidism, followed by skin and then liver and pneumonitis. So the conclusions from this real-world evidences experience show that first two reported real-world study of durvalumab and chemotherapy from India and Italy, significantly higher proportions of gallbladder malignancies were included, majority of them being PS2 or higher in the Indian studies as compared to the trial world. PFS, OS, and response rates are almost similar to what we have seen in the Topaz 1 clinical trial. Overall survival is slightly lower in the Indian study due to a greater number of the gallbladder cancers and potentially lower use of second-line targeted therapies. No new safety concerns and toxicity was acceptable with no unexpected side effects. Therefore, the combination of durvalumab and chemotherapy appears to be safe and efficacious in biliary tract tumor. So, post 2022, when this drug came, it has become now category 1 in NCCN guidelines as well in 2023. And durvalumab has been given the category 1 recommendation in primary treatment of unresectable and metastatic BTCs. So, to conclude, we can say that durvalumab plus GEMSIS demonstrated a statistically significant and clinically meaningful prolonged overall survival as compared to placebo plus GEMSIS in both the phase 3 studies as well as the real world data. Safety wise, no additional toxicity was seen, no new signals were seen. If we talk about the biomarker status, so not a great data which has been studied is only post hoc analysis and more or less appeared to be effective across the molecular landscape of the BTCs, and the patient with targetable genomic alteration benefited from the addition of durvalumab in the first line. So a dose of 1500 milligram in combination with chemotherapy has been approved, followed by maintenance every 4 weeks. So these are the drug informations, and thank you all for your patience listening.
Okay, thank you so much, Dr. Ankit Patrasan. Is there any question? Okay, moving ahead for the next session, and this session is sponsored by Merck. And I would like to invite Dr. Varun Goel, sir. He's a senior consultant, medical oncology, Rajiv Gandhi Institute, Delhi. And he's talking about evaluation in advanced UC treatment to achieve max survival in patient. So it's over to you, sir.
So, good evening, everyone. First of all, thank you, organizers, Dr. Rajat, Dr. Manish, and Dr. Udeep for giving me this opportunity. So, let me share my slides. So, please let me know whether my slides are visible.
Yes, sir. Make it full screen, please.
Yes, yes.
Yes, it's visible now.
1 minute. So today I'm going to discuss regarding what is the role of maintenance treatment in metastatic urinary bladder cancer patients. So as we all know that these are aggressive cancers, and if patient diagnosed in advanced stage and or recur, then survival is dismal, and there is high unmet need to improve the management pathways and management approaches for these patients. So what is the current treatment approach for to extend survival in these patients? This is the topic which I'm going to discuss. So first of all, we should divide our patient whether the patient is cisplatin eligible or ineligible based on the criteria regarding patient's heart status, neuropathy, if there is previously any comorbidity leading to neuropathy, and ototoxicity, so hearing loss already if there or not, and obviously if GFR is less than 40 or not. So at present, according to literature, if GFR is less than 50, that patient should be cisplatin ineligible, and that patient can be given carboplatin. Although in real world setting, till cisplatin until GFR of 40, we can give cisplatin, although in split dose of day 1 and day 8. And till 25 of GFR, we usually give carboplatin. Below that, we usually avoid any platinum. So we divide our patient whether the patient is cisplatin eligible or ineligible. In few patients, we give carboplatin. And so we have given chemo. And after that, we have 2-3 options as a maintenance. Either we can wait and watch, and on progression, we can give the treatment. So many patients till the recent last past, we use this approach only. But this PFS is very short, and most of the patient progress within 3 months or maximum to maximum 6 months follow-up, and then we have to start second line treatment. So next approach is that we can switch maintenance in the form of avelumab. So first line chemo, and after, if patient get complete response, partial response, or at least stable disease, then after after 4 to 6 cycle of chemotherapy, we can switch to Avelumab. So this is called switch maintenance, and on progression later, we can initiate second line treatment. Third approach is to continue the maintenance. So for that, if we have already given immunotherapy along with the chemotherapy in the first line, that in the form of gemcitabine, cisplatin, and nivolumab, and then if patient achieve CR, PR, or SD, then we can stop chemo and we can continue immunotherapy in the form of nivolumab, and on progression, we can go to second line treatment in the form of second line chemotherapy. So with the wait and watch approach, as I've told you, median PFS is too short, and overall median OS with this approach, even after giving second line pembrolizumab, is 16 months. So obviously, patient may argue, may discuss that if not as a maintenance, what happen if patient progress, then we can give immunotherapy. But with that approach, on progression, if we give immunotherapy, median OS is 16 months only. With switch maintenance, which is now, as I may say, that is a standard of care, and this is the main to-go approach which we usually practice in our clinics. So with this first-line chemo, after that switch maintenance as a form of, in the form of Avelumab, and on progression, second-line treatment is usually given. And this is based on the Javelin Bladder 100 study, which was a phase 3 randomized open-label study in which induction therapy, either cisplatin or carboplatin, have been given based on the eligibility criteria of platinum. So then patient was given Avelumab in the dose of 10 milligram per kilogram Q2 weekly, and otherwise follow-up only till progression. And so in this study, they have taken around 700 patients and randomized 1:1 ratio. And they have given this IU maintenance, switch maintenance. There may be after chemotherapy till 10 weeks interval. Primary endpoint for this study was overall survival. Second endpoint were PFS, OR, time to response, response duration, disease control, and all. They have analyzed all the population at all together, and then they have subgrouped the patient on the basis of PD-L1 positivity. So this was the median OS. If we start from the start of the chemotherapy, then 30 months of median OS benefit with the Avelumab maintenance arm from the start of first-line therapy have been achieved. So remember, I have shown you in the last slide that if we give just follow-up and then Pembro on progression in the second line, then median OS is around 10 months only. And here with switch maintenance in the form of Avelumab, and after that second line treatment on progression in the form of next line chemotherapy in the, either PACLI or GEM rechallenge based on the patient PS, then here median OS can be achieved till around 30 months. So this is unheard of in metastatic unibladder patient before this trial. And so obviously this is very, very clinically significant and relevant. So there is 9.2 months of improvement in median OS if we, in this trial, if we compare from the chemo followed by follow-up followed by second line. So 23% reduction in the risk of death with the switch maintenance. Median PFS with Avelumab is 5.5 months, while with the follow-up only it is 2.1 months only. And this is also statistically significant. This overall survival benefit was observed irrespective of the number of first-line chemotherapy. So it is not required to give full 6 cycle of chemotherapy. So in some patient, we may give switch maintenance even after 4 cycle of chemotherapy. If we treating clinician feel that major tumor burden have reduced and patient is now asymptomatic, and now or otherwise if patient having side effect with the chemotherapy, and so we can switch even after 4 cycle of chemotherapy to this switch maintenance in the form of Avelumab. So OS benefit with this first line maintenance Avelumab occurred irrespective of the first line chemo regime. So it is not depending that we have to give cisplatin only after, even only after that we can give this switch maintenance, even after carboplatin, as in this study they have recruited those patients also in which carboplatin have been given as a first line treatment. So these minor points are important because if we compare with the Gemcis plus Nivo followed by Nivo trial, there they have not taken carboplatin patients. So in the real world clinics, it is important to see what is the effect of using carboplatin in the first line, because many patients are associated with nephropathy or other cisplatin eligibility criteria, and we have to give carboplatin to those patients. So because that trial have excluded carboplatin from the use. So if in a patient we can't use cisplatin, we have to use carboplatin, then according to study and according to trial, we can't use nivolumab along with an AJ maintenance also. So this is important. Regarding OS and PFS benefit with Evlumab, it is irrespective of the response of the chemotherapy. So logically speaking, it looks like if patient have already achieved complete response, then with the switch maintenance, there may be more PFS or OS benefit, but it is irrespective of whether patient achieves CR, PR or ST. In all patient, Evlumab maintenance will provide OS and PFS benefit. So in Asian subgroup, which represents 1/5 of the overall population of the Javelin bladder trial, so if we see specifically in this subgroup, then this patient also shows OS benefit as of the overall patient population. Many times we have seen that because of the genetic diversity, so Western literature data is not replicating in our Asian country population, but here, although number are less, but 1/5 patient are of Asian population, and results are same in these patients also. There is significant improvement in the PFS and OS if we use this switch maintenance after first line platinum based chemotherapy. Regarding safety profile with the Vivencio, we all know we have already used in many patients, and we can say that this drug is very, very safe, and we haven't seen any significant immune-related adverse event with this drug. And if any, those are mainly grade 1 or 2. There is no new safety signal, and no only few patients with grade 3 like transaminitis and pneumonitis or hypothyroidism, but that can be managed. So efficacy of Evlumab first-line maintenance has been confirmed in real-world heterogeneous population, and if like that is around 700 patients, out of which 350 patients have been taken for Evlumab in Javelin trial. Later in real-world setting, different other studies have been done, and so overall, if we combine those, so more than 1,200 patients have been given Evlumab first-line maintenance, and in Avalanche and Reddy study, and they also shows concordance with the Western literature and shows similar results in the form of improvement in the PFS and OS benefit. So this Avalanche study, it is an ongoing multi-center ambidextrous, that is retro and prospective study, non-intervention study, mainly observation study in these first-line unibladder patients with Vivencio maintenance. So in this study, although even better OS have been reported, if we compare with the Javelin, there is 30 month here, 40 month of overall survival, one of the largest real world study which have shown this in this study. So it is with second line and enfortumab vedotin. So obviously first line platinum based therapy, after that response, Evlumab, second line, no chemo. In this study, they have given enfortumab, and that even increased the survival to 40 months. Now coming to third approach, that is continuation maintenance. So if we are given immuno with a chemo only, and after that we continue immuno and stop chemo. So then what? Like, is there any difference or almost same? It should be physician preference, either to approach, or there is difference in the PFS and OS. So there is difference. So I'm coming to those slight differences, but important clinically. So if we see this in this Checkmate 901 study, so no carboplatin have been used, only Gemcis as a chemo arm. So this study, although have achieved PFS and OS endpoint as per statistical analysis, but if we see PFS improvement is only few months, maybe less than 1 month. OS improvement is only 2.5 months. So hazard ratio is 0.78, but very minuscule benefit in PFS and OS if we have used this continuation maintenance approach. So in this study, that is Checkmate 901, Gemcis with Nivo followed by Nivo alone as a maintenance have been given. So here also around 600 patients were taken. So this is PFS benefit 7.9 versus 7.6. So only 0.3 months of benefit of PFS with this approach. And we can see that this benefit, slight benefit, this happens this separation of curve happens after 6 months of treatment. So before 6 months, because both the arms are having chemotherapy, so main response is because of the chemotherapy. There is no extra benefit of nivolumab. And even after that, separation of curve is there, but benefit of median PFS benefit is only 0.3 months. Similarly, very minuscule benefit in OS, just 21.7 versus 18.9 months. P-value is 0.01. So here also we can see that both the lines, although are well distant to each other, but crossing very like not crossing, but are very nearby. 2.8 month of median OS increment with this continuation maintenance approach. So if we see GEMS followed by avelumab maintenance patients, so only 11% of the patient have received this approach. So at the time of design of this trial, checkmate trial, standard of care is chemo followed by Bavencio. So why not they have taken control arm that same chemo followed by Bavencio? They have taken control arm is GEMS followed by follow and no treatment. So only 11% patient have received avelumab. So comparator arm is not standard as per standard of care in this study. Unprecedented overall survival benefit observed with avelumab maintenance. So in Javelin study with avelumab, there is 9.7 versus 6 months benefit in cisplatin eligible benefit in the form in PFS, while in OS it is 31 versus 23 months, 8-month benefit. While in checkmate study, benefit is in PFS is 0.3 month only and 2.8 month only in the OS. So that's why this approach as a continuous maintenance is not very lucrative and not like we are very impressed of, and we are going to change our clinical practice with this with the result of this study. It is not like that. Approach to maximize the OS. So like IO upfront in combination of IO and followed by ADC. So here, if we give continuous maintenance and then initiate second-line therapy in the form of enfortumab, so what happens? So this is third another approach in which this EV keynote in 39 study, in which EV plus pembro have been given in previously untreated patient in the first line versus chemotherapy. Here overall survival benefit is there, no doubt. With EV plus pembro, p-value is statistically significant, hazard ratio is 0.47. Risk of death reduced by 53% patient in which EV plus pembro have been given compared to cisplatin based chemotherapy. And but these extra benefit in the OS is with the cost of increased side effect. So there are significant high grade 3 skin reaction, papillopathy in the form of sensory and motor neuropathy, ocular disorder. Ocular disorder mainly grade 1 or 2, but still 15% patient with grade 3-4 skin reaction, 6.8% patient with grade 3 papillopathy. Although with chemotherapy, grade 3 side effects are rare. Most of the side effects are grade 1 and 2 and reversible. So overall, if we see, so overall survival with the Nivo GC, Nivo plus Gemcis and only, that is 21.7 month. But if we go with Javelin bladder 100 trial results and approach in which chemo followed by maintenance treatment and then second line treatment, then we can see OS of 29.7 months. With EV plus pembro, OS is 31.5 months. With avalanche approach, which includes Javelin approach also. So we give platinum-based chemotherapy followed by amilovab, followed by ADC, and here survival time with this approach is the maximum, that is 40 months. So it is even more than that if we give EV plus pembro followed by second-line treatments in the form of chemo, because pembro already have, if we use in the first line, EV also if we use in the first line, even then survival is 31 months. So best approach is according to Avalanche approach We give chemo followed by switch maintenance, followed by ADC in the form of EV, and then later on, according to patient PFS, PS, if any other chemo we have to give. Overall survival in this approach is 40 months. So to summarize in some take-home message, treatment landscape of metastatic urinary bladder cancer patients is evolving. Platinum-containing chemotherapy obviously has high initial response rate. Wherever possible, if no contraindication, even till GFR of 25, we usually go ahead with the platinum-based chemotherapy as a first line. But responses are not long-lasting, so obviously some form of maintenance treatment have to be given to improve the PFS and OS. Till now, with all the results and available data with us, maintenance avelumab significantly increase the overall survival. If we just see chemo followed by avelumab and followed by second line chemo, it is 30 months. But if we add EV in the second line after switch maintenance of avelumab, then sequencing of available option in EV after first line avelumab maintenance, it results unprecedented OS of 40.8 months. So Pembro EV data looks good, but there is significant toxicity profile and very high dropout rates. Nivo GC followed by Nivo, although a positive study, but there is very, very minor increment in the PFS norms. So thank you. Over to you, organizers.
Thank you so much.
Yes, ma'am.
So wait for 1 minute. I will connect with Dr. Rajat Bajaj. Okay, so I think Dr. Rajat Bajaj sir is in OPD. I think he's busy. So thank you so much all the speaker for today's session and yesterday's session. And thank you so much all the delegates and pharma colleagues to sponsor this session. Thank you so much. Lupin Oncology, Roche, Fresenius Kabi, AstraZeneca, Ares, Merck, Intas Oncology, Cibla Oncology, Eisai, Takeda, Dr. Reddy's, Novartis, Zydus, Pfizer, and Media. Thank you so much for the participating, sir. Thank you, Tech Support, and thank you, Manisha.
Thank you, Gitika. Thank you, Manisha. And thank you, Tech Support. Uh, Thanks everyone for joining. Good night.